We're going to be talking this week about assessment with infants and young children. Wanted to start off class today just by giving you a little bit of an update on sort of the next direction in this course for the next few weeks. Now that we've talked about some of the basic aspects of psychological assessment and psychological measurement, we're going to turn our attention now for about the next 4 lectures to how we assess and what sorts of issues we assess with different age groups. And so today we're going to be talking about assessment with infants and young children. And we're going to be focusing this discussion around the idea of human development. And so we're going to spend part of each lesson sort of talking about the developmental issues that people face in specific developmental stages. And then we're going to talk about what psychologists need to do to assess those issues in the various age groups. So I wanted to start today with a little bit of a review of developmental theory. And I know that you've all had classes on developmental theory. I know you even covered some of that in Introduction to Psychology. So I won't spend a lot of time on that, but I want to just give a brief overview, and then we'll go on and talk some about psychological assessment with this age group. So just a reminder that a lot of the developmental theories that we use most frequently, the most common ones, are what we call stage theories. And these suggest that human beings develop in a series of stages, and that each stage focuses on completion of a specific task or resolution of a crisis. And in these theories, the idea is that these stages build on each other, and that most people progress through similar stages. So that what happened to me when I was 3 years old is pretty similar to what happened to you when you were 3 years old, even though I'm 20 or 30 years older than you. And one of the things we need to think about in terms of psychology, and in terms of especially thinking about psychological assessment, is what happens if people don't progress to the next stage that we think that they're going to progress to. So failure to progress to the next stage, or failure to master the developmental tasks or resolve the developmental crises, that usually indicates the presence of some sort of pathology, some sort of problem, and that's the sort of thing that we would usually need to assess for. Two of the most common models or theories of human development, the ones that we're going to focus on mostly in this class, these are Jean Piaget's theory of cognitive development and Erikson's theory of psychosocial development. So we're going to be in each lesson for these next few weeks, where we're talking about psychological assessment in various parts of the lifespan and various developmental stages. These are the two models that we're going to be focused on, Piaget and Erikson. Before we go on, I wanted to make a few comments, and I always think it's important to do this just in terms of some criticism of our models that we use for understanding developmental theory. One criticism is that these models seem to have been based on males of European descent. And so the issue with that, of course, is that we're not sure that these stages are quite so accurate for people who might have been born in Africa, or for females. A lot of these theorists were people who were writing and teaching and doing research in the early to mid 1900s, and they really focused on, a lot of them focused on their own stories. Erikson's theory, his developmental theory, actually focuses quite a bit on his own life story. It kind of mirrors his life story to some degree, actually to a pretty good degree. So of course there's questions about applicability to other cultures and genders. Another criticism is that even though spirituality and faith are usually a very strong component for many people of their developmental process, a lot of theorists don't address this. Now, Erikson does. Fowler, who develops some stages of moral development, he addresses this. We're not really going to focus much on Fowler. Erikson does mention spirituality or faith, but in general, this isn't something that our developmental theories focus on a whole lot. Finally, the other criticism that's commonly made about the developmental theories that we use is that they're very individually focused, and so they don't always do a good job of accounting for social and environmental factors. It sort of suggests that most of the developmental processes are just focused on individual actions, behaviors, that sort of thing, and maybe doesn't account for the fact that where you live, how you're brought up, how you're raised, that those sorts of things can have a strong impact on your development. For example, people who grow up in abject poverty, people who aren't sure that they are going to have enough food to eat, that may affect their development in many ways. It may affect it cognitively, it may affect it physically, it may affect it emotionally. And that may affect their ability to resolve the crises that are the focus of these developmental theories that we're looking at. Okay, so just a little bit of a review of what's going on in Piaget's stages. Today we're going to be talking about people from about 0 to 5 years old, so infants, toddlers, young children. We're going to be looking at their development and an assessment with those groups, or with those ages. So Piaget says that in terms of cognitive development, here's what's happening between about birth and age 2. Piaget says we start to develop goal-directed behavior and learning. We move from reflexive behavior, for instance, sucking, feeding, to gaining control over our body. And so again, going back to this idea of goal-directed behavior, as we learn to control our body, our behavior becomes more purposeful. We become more able to use our body to meet our needs, to gain what we need. We gradually become aware of external objects. And by objects, we don't just mean physical objects, but we also mean people that we have relationships with. Sometimes we talk about attachment objects. And we become aware of the ability to manipulate physical objects. So I can move this cup, I can move this ball. Object permanence develops. This is the awareness that an object exists even when it's not seen. This develops closer to 2 years old. So before you're getting, into being close to 2 years old, if you have a book that you can see and then somebody moves it away, it's almost like you don't realize that that book still exists. And so once you develop the recognition or the awareness that that book still exists, even if you can't see it, we call that object permanence. We also develop representational ability, and these two are related. We develop the ability to remember what an object looks like, even when we can't see it. So those are some of the things that happen during the sensory motor stage, which is about 0 to 2 years old. And then the next stage, we're not going to cover this whole stage today, but we'll cover most of it. Piaget says that from about 2 to 7, we're in what's called the preoperational stage. And this is broken down into 2 substages. The preconceptual stage, which is about ages 2 to 4. This is where language development starts to take place. We also see children starting to be able to do imaginative play, and so they can even resolve conflicts through imaginative play. One example of this, I've got a daughter, Katie, who's now 15 years old, but when she was a little girl, she was very scared by this story about Little Red Riding Hood. Many of you have heard this story, the story where a wolf eats the grandmother and tries to attack Little Red Riding Hood. And Katie was really, really scared by this story, but she was also sort of fascinated with it. And she had this doll that was Little Red Riding Hood and turned into a wolf that was dressed up like grandma. And even though she was scared by the story, she kept wanting to engage in imaginative play with this doll. And eventually she was able to resolve that conflict, that fear of that story, by playing with that doll enough that she gradually sort of developed the ability to not be scared by that story anymore. So that's sort of what we're talking about in the preconceptual period, where language is developing, but also children are developing this capacity to imagine things and to play, to make believe, that sort of thing. The next step then, or the next substage, is the intuitive period. And this is about from 4 years old to about 7 years old. And what happens here is we see the beginning of development of math skills, and children start to be able to number things, to classify things. They start to understand how different ideas and objects are interrelated, how they're related to each other. So if you've ever been at a young child's school, in the U.S. we often have children that start preschool at 3 or 4 years old. Our children would come home from preschool at 3 or 4 years old, and they'd be working on patterns. They'd be able to say, here's a pattern of a circle, a square, and a triangle, and then I know that the next step in that pattern is going to be a circle. So they're starting to get this idea of classifications, relationships, math skills, those sorts of things. They're going to be able to say this is a cup compared to this is a bowl, so they can classify things into different categories. Children become increasingly social, so this is the age at which they start to make friends, and they start to test out their ideas socially. They start to kind of do these little experiments with their friends, and that's kind of typical for this age group. However, at this age, there's still a great deal of egocentrism, which means that children at this age aren't really able to incorporate other people's points of view. So children aren't going to say, oh, I understand that you see it this way, but I see it this way. At this age, there's still really only one point of view, and that's my point of view as the child. They also engage in animistic thinking, meaning they ascribe human characteristics to inanimate objects. So if you've ever had a child who really thinks that, you know, his stuffed animal or her teddy bear is a real thing, you know, even maybe acts like a human being, that's an example of animistic thinking. Also, children at this age, they live in the moment, so they're not really able to track moment-to-moment changes. So it's sort of like the only thing that's happening is what's happening right now. They can't really sort of progress from one idea to another in their head. They kind of have to just live in the moment. And similarly, they can really only focus on one aspect of a problem. So one thing that often happens at this stage is parents try to say, Johnny, I want you to go upstairs, get your slippers, and come back downstairs. Those kinds of sequential directions, those are going to be very hard for a child at this age because they can kind of only focus on one thing at a time. So there's Piaget stages for the age group that we're talking about tonight, the 0 to 5 years old stage. Erikson looks at things a little bit differently. He's looking at psychosocial development. And so Erikson says that in the first 18 months of life, in the infancy stage, Erikson actually breaks his first stages, the age group that we're talking about now, into 3 stages: infancy, early childhood, and preschool. But Erikson says that in that infancy stage, the developmental crisis, or the thing that children are trying to work out, is trust versus mistrust. And a lot of this relates to their caregivers. Can I trust mom or dad to take care of me, and to give me affection, or are they the kind of parents that are going to just leave me to cry, hungry and dirty in a crib? And this is where we start to get into attachment issues. And a lot of you are probably aware of attachment from other classes. We'll talk more about that in a minute. Early childhood stage for Erikson, about 2 to 3 years old. This is when we get into autonomy versus shame and doubt. So children start to be able to do some basic things on their own, or if they can't do that, then they fall into shame and doubt. And so a lot of times this stage focuses on things like being able to control myself, like toilet training happens primarily at this age, physical skills, a little bit of independence, a little bit of control over one's life. If the child can do this, then they feel autonomous, they feel like they have some personal control. Otherwise, they tend to feel shameful and sort of they doubt themselves. And then the final stage for Erikson during this 0 to 5 year period, he says that from 3 to 5 years old, we're in the initiative versus guilt stage. And this is where we're trying to assert power or control over the environment. You know, so I want to be able to not just control myself, but I want to be able to sort of control things around me. But if I get too kind of bossy, if I try to take too much control, usually my parents, my teachers, my older brothers and sisters become very disapproving. So if I'm sort of too strong-willed here, I actually start to feel guilty because the people around me don't like that. And if you've ever been around a child who has a very strong will, and most of them do at some point or another in this process, you can understand why sometimes the parents have to sort of clamp down on them, and then there are these guilty feelings for the children. So Erikson would say that children have resolved this stage when they learn how to take initiative, but they also learn how to do that in a proper way so that they're not kind of stepping on the toes of other people around them, not angering authority figures, that sort of thing. Okay, so that's a little bit about just a little bit of a review of the developmental stages as Piaget and Erikson see them for the age group that we're talking about tonight. I wanted to just go over a brief list of some of the early childhood issues that psychologists might have to assess, or things that might bring a child into us for assessment. One thing would be language development. We usually see children starting to try to talk somewhere between 1 and 2 years old, sometimes even a little bit before 1. And there are some variations. A lot of people say that younger children, you know, if you've got, that younger siblings, that they tend to talk a little bit later than only children or first children. But in general, if we don't see language developing within that time span that we sort of expected to, then we're worried about delayed development. And a lot of what we're going to talk about tonight with assessment of early childhood issues is developmental delays, or something that doesn't happen, a benchmark or a threshold that a child doesn't meet within the time that we expect them to. And it's not like we have this time down to a day or a week, but generally we have age ranges where we know that children should be able to develop these skills and these abilities. And if they haven't developed them by a certain point, then we start to be concerned that maybe their development is delayed in some way. Social skills would be the same way. Social skills would be the ability to relate appropriately with same age peers. If we don't see children developing that ability to to engage socially, then we become concerned. For example, children who are diagnosed with autism, often one of the diagnostic features of autism is what we call parallel play. And this is where you might have a child sitting right next to a group of children, and maybe the other 3 children are playing with blocks and they're building a tower. The child with autism might be sitting very close to that group and doing something similar, building a tower with blocks, but he's really not engaging with that other group of children. And so then we'd see a social skills deficit or delayed development in terms of social skills, and that might be one of the features of autism. It's one of the symptoms. If the child has the rest of that constellation of symptoms for autism, then he or she would be diagnosable. We also see emotional development happen at this time, where children start to be able to express their emotions. And again, with autism, that would be another feature where often autistic children have a very blank affect or a flat affect, meaning that they don't show emotions. Sometimes they do, sometimes they tantrum, but sometimes there's this very flat affect. We also see motor development at this stage, great advantages in motor development. The gross motor development happens first. These are sort of the big movements, and then later in childhood we see fine motor skills developing. I mentioned attachment earlier. We do see attachment issues at this age. This is often when they're first diagnosed. We often are looking for secure attachment. Well, I'm sorry, what we're hoping for with children is what we call secure attachment, meaning that the child has a bond with his or her caregivers, ideally with his or her mother and father. And the mother often is the first attachment object because, of course, the mother is feeding the baby and that sort of thing. So in a healthy relationship with a child that's developing normally in terms of attachment, we see attachment, we see what we call secure attachment with the mother. However, sometimes children don't attach securely, and then we talk about them having insecure attachment. Sometimes this is the result of parental actions. Parents, for example, who are on drugs often ignore their children, neglect their children, leave them in cribs and playpens, and don't attend to them, and then we see children developing insecure attachment. We also saw this in a lot of children who were raised in institutions like orphanages and that sort of thing, which is why more and more we try not to put children in institutions. If children can't live at home, we try to put them in foster care or in placement with family members so that they are still attaching to somebody rather than having staff rotating in and out of their life. And so attachment would be one of the other things that we're looking at. If that's not developing, then we start to be concerned that we need to assess what's going on with the child. And we even need to assess what's going on with the attachment. Is the child attaching normally or not? We also see the need to assess behavioral control sometimes in children. I mentioned earlier that children with autism sometimes tantrum. And what we have to do sometimes as psychologists is we have to determine, is this normal lack of behavioral control? In the US, we talk about the terrible twos, sometimes the threes are even worse. Sometimes we sort of joke about the terrible threes. But this is an age where children are really testing the limits, and sometimes they behave very badly, and sometimes healthy, normal children tantrum. Children that tantrum a whole lot, that could be a symptom of autism, and so that might be another issue that we have to assess. We also look at social skills development. Sorry, I mentioned that one earlier. That got on here twice, so I won't go through that again. Some other early childhood issues that come up, sometimes we see issues arise in childcare or daycare. Sometimes some of these issues that we're not seeing at home, but in terms of social skills and language development, sometimes they may become more apparent in childcare or daycare settings. I've already mentioned autism, but often we start to be able to recognize autism at 2 or 3 years old, and that's a really good thing. So we're going to talk in a minute about the importance of early intervention. We also sometimes see the emergence of diagnosable behavior and psychological disorders at about this age. And so we might start, especially at the later end of this age range in the 4 and 5 year olds, we might start to see things like some of the disorders that are normally diagnosed in childhood and early adolescence, or I'm sorry, in the DSM when we talk about disorders that are normally diagnosed in childhood, we could start to see some of those very early in a child's life. The other thing that we might have to assess, and I think if I understand correctly, this is an issue in Lithuania as well as in the US, is whether a child's ready for school or not. And I remember some of my friends when we lived in Lithuania, some of my friends telling me that that if you want your child to start in kindergarten, it's darželis there, right? I think I'm probably saying that wrong, but that if you wanted your child to start in that in those classes, before they were 7 years old, they actually had to see a psychologist who had to say, yeah, they're okay to start, or no, we think they need to wait. But you couldn't just sort of say, oh, I think my child's ready, and put them into school. And here in the US, we often run into that too, where we have a psychologist that's looking at, is this child ready to go to school yet or not? So those are some of the issues that we might have to look at in early childhood. Some things to keep in mind when we're thinking about assessing infants and young children. There's a lack of predictive validity for cognitive tests that are administered prior to age 6 or 7. And here's what that means. We might have a child that tests low on tests of cognitive ability or IQ tests. That doesn't always necessarily mean that they're going to have cognitive delays when they get older. Sometimes it seems to be more of a testing issue. So that leads to this concern that if we test children too much too young, we might apply false labels. And if you know anything about sociological theory, one of the theories that sociologists talk about sometimes is labeling theory. That if we label people in a certain way, if we say this child is developmentally disabled or developmentally delayed, that can affect their whole life. That label can follow them, and they can start to live up to that label. It sort of becomes what we call a self-fulfilling prophecy. So we want to be really careful about applying labels to young children because they're still developing, and children tend to develop at different stages and different ages. Another thing we need to keep in mind when we assess infants and young children, if you're working with an adult, you can often just give them a psychological test and you don't need to meet with anybody but that adult. However, when you're assessing infants and young children, because they can't tell you accurately what's going on, you're going to need to involve parents, and you're often going to need to involve other caregivers as well. So it's really important to involve the parents and the caregivers, and it's really important too, and your book talks about this, it's really important to be careful how we do that. We don't want to just sort of hand the parents a stack of papers at the end of the session and say, hey, fill these out. We really want to try to enlist their aid as collaborators, as people who are really involved in this process. We really want to get them invested so that they don't just see this as a burden, but so that so they understand the importance of being involved and they have some investment in being involved. Another thing we need to keep in mind when we're talking about assessment of infants and young children is there's really a need for early intervention. With a lot of the disorders that we diagnose early in childhood, if we can diagnose them early, we can really help children to get the assistance that they need with that disorder. I want to take a minute and when I'm talking about early intervention, I want to take just a minute. I've got a short video that I want to show you about autism that will highlight a little bit the importance of early intervention. It shows how if we intervene early enough, we can actually help to reverse the symptoms of autism. So I want to just stop here for a minute, switch over to this video, and then we'll come back and finish up the last few PowerPoint slides. This video might come out sort of loud, so if you need to turn your speakers down, please do that. Also, the link to this, I will post that online. If you're having trouble hearing the video, you could just link to it yourself after the PowerPoints are over.
As we said before the break tonight, a groundbreaking but small new study is offering hope to so many families that just maybe there could be a way to reduce the symptoms of autism spectrum disorder if you catch them early enough. The numbers, as we've reported, are staggering. 1 in 68 kids now diagnosed within the spectrum. This new study is a small one, as we said, and it's preliminary, but it could lead to significant changes in the way parents flag those early symptoms and then help their children. We get our report tonight from our national correspondent, Kate Snow.
As a baby, Isabel was unusually fixated on objects. Say, good morning, Isabel. And she wouldn't turn to look at me. She'd still just be looking at the bars on her crib as if I wasn't there.
So when her parents heard about the work Sally Rogers was doing, they moved the family to Northern California to be part of her study of 7 infants.
Parents aren't asking us, where do I find therapists for my child? Their very first questions to us are always, what can we do?
Like Isabel, the babies all showed early signs of autism, not seeking a parent's attention or interacting, abnormal repetitive behaviors or fixations, not making age-appropriate sounds like mama or dada. For 12 weeks, researchers taught the parents how to read cues.
Not too much, okay. We learned to pick up on just a little glance of her eyes away or a tiny frown.
When the infants made sounds, their parents were coached to celebrate, to reinforce that communicating matters. Reading with their child in front of them instead of in the lap became a way to force eye contact. The change in Isabel was dramatic.
December of 2011, she was 8 or 9 months, and that was a very typical look, just kind of disengaged. And then this is April of 2012, and that, I mean, it makes me want to cry just looking at it. It's it's just light years beyond where she was.
Isabel is 3 now, an age when many toddlers are just being diagnosed with autism. She's no longer on the spectrum at all. Of all 7 infants studied, 6 caught up on learning skills and language, a hopeful sign, but every child with autism is different.
I think parents should be reassured that the earlier we start intervention, the better, but it's never too late.
And these methods need to be tested again in larger studies, but even this pilot study offers encouragement that perhaps very early intervention plan can make a difference.
This was as we said, a small study, big results and big news tonight. Case, no thanks.
Okay, so you can see. Sorry about that. Another video came on. So you can see the need for earlier intervention. You can see why that's important. One of the researchers near the end said, you know, it's never too late, and that's true. But having read and seen some other information about these sorts of studies, it does seem that the earlier we intervene with children with autism, the better. And that may also be the case for some other developmental delays and that sort of thing. And so we really don't want to take an approach as psychologists where we tell parents, oh, just wait and see, watch this. Sometimes that really could be hurting their child's chance of developing normally. And so being able to intervene early is often very important. The other issue that comes up sometimes around the assessment of infants and young children is the whole idea of, is it developmentally appropriate to test children? And usually it is, but what we don't want to do is develop a test or use a test that would require the child to do something that just isn't developmentally appropriate. So children aren't going to be able to sit still for a really long time. They're not going to be able to focus their attention for really long times. And so we want to be careful about using tests or developing tests that would require something that children just aren't capable of doing. Okay, so I want to talk a little bit about some common approaches to assessing infants and young children. One of the first that we use in the US at least is APGAR, and this is often done at 1 minute and 5 minutes after birth. And here we're just looking at activity, pulse, grimace, so is the child making facial expressions, their appearance, so they're evaluating the child's appearance, and respiration or breathing. So that's a very simple test. And you'd even maybe hesitate to call it a psychological test or a psychological assessment at all. But sometimes when we assess people, we do ask about their experiences right after birth. For example, if the umbilical cord was wrapped around a child's neck when it was being born and there was a lack of oxygen, that may show up on their APGAR score because it may affect their appearance, it may affect their activity level, and that can also, as you know, the lack of oxygen to the brain can cause brain damage. And so that APGAR score, while it doesn't tell us a lot by itself in psychological terms, it might be part of the picture of understanding what's going on with a child. Another approach that we use is questionnaires that would be completed by parents or other informants. And by other informants, we mean other key people in their life. Could be grandparents, could be teachers at preschool, could be a babysitter, that sort of thing. I'm not going to go through all the different questionnaires we could use, but I wanted to just mention a few that are mentioned in the book, just to give you an example. The Gesell development schedules would be one example, and this questionnaire looks at 5 different domains: gross motor skills, fine motor skills, language development, adaptive behavior, and personal social behavior. And these would be questionnaires that would be completed by parents or other key people. There's also another one called the home observation for measurement of the environment. And this looks at parental responsiveness or involvement, organization of the environment, and infant stimulation. There's also the parental stress index, which is just like what it sounds. It measures sort of how the parents are doing and how that might be affecting the children. As children get into the older end of this range, the 4 and 5-year-old, we might be interviewing them. Now, again, they're not going to sit for an hour and a half assessment session like an adult or a teenager will, but we might be able to sit and talk to the children some, and that might give us an understanding of some of what's going on with them. And we may do what's called the mental status exam, which is where we sort of keep a record or make observations about the child's mental status. And of course, finally, the other thing that we may do to assess infants and young children would be psychological testing. So I want to just talk for just a minute or two about some of the different kinds of psychological tests that are commonly used to assess infants and young children. One that is fairly well known is the Bailey scales of infant and toddler development. We use this to look at developmental delays, to identify developmental delays in children. There's also the neonatal behavioral assessment scale, and this is used to look at infant behavior and communication. There's the Stanford-Binet test and the Wechsler Preschool and Primary Intelligence test. These both look at intelligence. And finally, another one that I wanted to mention that you sometimes hear about is the Conners rating scales, and these are for attention deficit and hyperactivity disorder. And I wanted to mention those before I finish tonight because you all probably know that in certain parts of the world, including the U.S., where I live, there's been a lot of concern, especially going back the last 15 years or so, 20 years or so, that we've been diagnosing way too many children with attention deficit hyperactivity disorder. And this is really a concern because often these children then are given stimulant medication. They're given Ritalin, Adderall. These are drugs that are actually stimulants and can make you high. They've got high abuse potential. Kids sometimes sell them to their friends. Kids snort them. They can make you high, and they can be drugs of abuse. And so it's really concerning that we're giving young children such powerful medicine. The other thing that's really concerning about the assessment of ADHD is often this is driven by people who don't know much about psychology. So it'll be a teacher who says, oh, Joey is just driving me crazy. He's getting up out of his seat. He's hyperactive. You should take him to the doctor and have the doctor put him on Ritalin. And, the parents take Joey to the doctor. The doctor often doesn't know much about psychology and testing, and he puts Joey on Ritalin. And then Joey's on these really powerful drugs from a very young age, and we don't think that's a good thing. And so having instruments like the Conners, before we're putting children on Ritalin and powerful drugs like that, before we're labeling them with ADHD, we want to have some good options as far as assessment measures to be able to look at that. Okay, that's it for the lecture today. Make sure to remember to take the quiz for this unit online once you get a chance, once you've read the book and watch this video. And I will talk to you again next week. Bye now.